Hello, I'm Yoon, a PhD student at the University of Michigan School of Information. I'm excited to present our work on shared responsibility and collaborative tracking for children with type 1 diabetes and their parents. This research was conducted with my co-authors Yasemin Gunal, Alice Wu, Dr. Joyce Lee, and my advisors Sang Park and Mark Newman. Managing type 1 diabetes T1D requires comprehensive tracking of various factors that impact blood sugar levels, such as diet, sleep, exercise, mood, symptoms, and insulin. However, tracking health data for children with T1D presents unique challenges as it requires active participation from both children and their parents. This is because children often lack knowledge and independence for data collection. Thus, collaborative efforts among children and their parents is crucial for T1D management. In recent years, there has been a growing focus on family informatics, and researchers have explored how technologies can facilitate collaborative illness management for patients and their family caregivers. Studies reveal that the involvement of family members can improve illness management by distributing tasks and creating collective strategies. However, there is a limited understanding of how young school-age children engage in collaborative tracking with their parents to monitor their health-related data. Previous research in collaborative tracking has focused on family members tracking their own data, often concentrating on specific types of information such as sleep or snacks. Thus, there remains a relatively unexplored area regarding how children can take a more active role in collaborative health tracking with their parents and how their responsibilities might be shared between them. Here, we define collaborative health tracking as children and their parents tracking children's data together to better manage children's health. Our study aims to investigate the benefits, challenges, and the strategies associated with responsibilities in collaborative tracking for children with T1D and their parents. Specifically, first, we identify different types of tracking approaches between children and their parents in collaborative tracking. Second, we highlight the challenges, strategies, and benefits associated with each type. Third, we offer design recommendations for collaborative health technologies for children and parents. We conducted a 3-week probe study using a data collection probe, a lightweight paper and digital tracking system customized for participants' tracking preferences. Before tracking, participants were given an opportunity to choose their probe medium and tracking topics. This allowed the probes to incorporate participants' varying needs based on their lifestyles and children's health conditions. To cater to participants' existing management styles, we prepared 2 versions of the probe, an app and a paper. The child and the parent were both allowed to select their preferred mediums. Participants could also choose at least 3 T1D related tracking topics that interest them. We recruited 22 pairs of children with T1D and their parents. The study procedure included 4 main phases: a first interview, a training session, data collection, and an exit interview. The first interview consisted of a parent interview, a child interview, and a probe customization session to help the participants customize their probes. After the first interview, personalized probes were created, and a training session was conducted to help the participants walk through the probes. After the probes were ready, the participants began the data collection and ended with the exit interview. Our findings revealed that parents and children shared responsibility for tracking in different ways, resulting in unique challenges, strategies, and benefits. We identified that tracking types were varied across 2 dimensions: responsibility for tracking management and responsibility for data provision. First, either the child or the parent took responsibility for managing tracking overall, including maintaining the log and performing the actual recording. Second, either the child or the parent was responsible for providing data, since the individual responsible for tracking might not have had all the answers independently. Based on these two factors, we identified the four types of tracking, which are child-independent, child-led, parent-led, and parent-independent. When children had skills and knowledge to independently log their health-related information, they took responsibility for tracking management and filled the information in the tracker by themselves. Despite their independence in tracking, some children frequently forgot to log data or made mistakes while recording. Several parents expressed concerns about their children's overconfidence or their inability to assess whether their children were tracking accurately, especially if there were discrepancies in data recorded between them. To overcome these challenges, parents established routines to check in with their child or review their child's logs to identify any missing logs. Through these tracking efforts, children became more aware of their T1D management and developed a feeling of independence. For instance, C4 was confident that he got more focused on his T1D management and was able to change his blood glucose device by himself during the study. Children in the child-led tracking approach took the lead in tracking while receiving support from their parents for data sourcing. Although these children showed motivation to record comprehensive data with the help of their parents, sometimes the parents did not possess all the answers to their questions, such as exact duration of the child's activities. Moreover, some parents felt challenged when seeking a balance between giving precise answers and not allowing the child to become over-reliant. As children often sought the system from their parents, parents tried to teach their child to acquire the data by themselves. To prevent children from becoming overly reliant, some parents chose to engage in discussions with their children rather than providing direct answers. Through discussions, children could learn skills related to data tracking, such as math skills for carb counting or time telling. This allowed children to become more involved in self-care. For example, C6 asked her mom about the carbohydrate amount in food. During the exit interview, she was happy that she got better at carb counting and now that she could do it alone on the upcoming camping trip at school. In parent-led tracking, parents took charge of overall tracking management while requesting data from their child. These parents strongly believe that subjective data types, such as mood, symptoms, and sleep quality, could only be accurately obtained by the child. Some parents used a combination of their own observations and their child answers for more accuracy. However, since parents requested information from their children often had increased feeling of surveillance, generating tensions between them. Some parents noted discrepancies between their own observations and the child's answers, leading to less trust on their child. To foster better communication with children, parents encouraged openness in discussions such as finding a time when children can better share their thoughts. When parents' observations and their child's responses diverged, they endeavored to arrive at a consensus through negotiation. Through these strategies, children became more open to discussing their health data, and child-parent had increased bonding opportunities. P18 pointed out that they would discuss the child's mood together and come up with a terminology that best describes the mood for logging. Parent-independent tracking occurred when parents took the responsibility of managing data by collecting it themselves through observations. This approach was primarily used for gathering objective data types, such as carb amount and insulin dosages. However, subjective data types such as mood or sleep quality, parents had limitations because their observation of their child could have been different from the child's actual data. For instance, although a parent thought that their child was in a good mood, the child could have been nervous. Moreover, when parents were not physically with their child, they would only able to collect partial data. To gather comprehensive data, parents try to gather data from others, such as siblings or school teachers. Overall, tracking independently allowed parents to have more flexibility and collect data in a timely manner. Moreover, their tracking behavior less influenced their child compared to the parent-led tracking type, allowing children to be more independent. The findings show that collaboration on tracking data extends beyond helping each other collect more accurate data. The collaborative efforts allowed the participants to learn skills and share different perspectives. Thus, collaborative health technologies could be designed to support these values for data collection. As active discussions around data collection have educational value for both children and parents, technologies could suggest discussion prompts between children and their parents on the collected data. Moreover, they could guide children to learn skills related to data collection, such as math skills for carb counting. Parents could also be provided with guidelines to effectively engage in discussion with their child. Our findings also highlight the importance of sharing different perspectives through collaborative tracking. Parents often cross-reference their observations to children's thoughts and opinions, especially for subjective data types such as moods or symptoms. To alleviate tensions related to surveillance and agency issues, technologies should be carefully designed to foster perspective sharing and effective discussions. Such a system could allow children to specify the extent of data sharing with their parents by selecting certain data components such as a tracking topic or time. Furthermore, to facilitate children's sharing of different perspectives on their parents' observation, children could be provided with an objection feature to their parents' data. Thank you for listening and feel free to email me if you have any questions.